Next up, we'll have Gina share with us the work related to a visual discharge preparedness tool.
Hi there. I'm Gina. As mentioned earlier, I've been a NICU nurse for 17 years. Always loved the babies, but I think after having my own child, leaving her at home with her dad to go to work, it changed my perspective on what NICU parents must feel leaving their baby in the hospital with a stranger. That really changed my nursing practice. And then after 12 years on night shift, I moved to day shift where I get more FaceTime with parents and just really discovered I also have a passion for family integrated care. So a few years ago, I joined the Define Collaborative at Highlands Ranch Hospital. And through our post-discharge parent surveys, as well as staff feedback, identified that we have an opportunity to increase our family engagement by streamlining our discharge preparation and education, which led to the Oh, yes. So sorry. Okay. This led to the creation of the NICU discharge roadmap. Like Liz, this was part of my UXL project. Background is a little bit of what we've talked about already today. Infants in the NICU experience prolonged admission and are discharged with complex medical needs. When they're discharged to an unprepared caregiver, they're at increased risk for adverse outcomes, healthcare utilization, and even hospital readmission. Additionally, the families and caregivers that are unprepared may experience additional stress and cost. Family reported satisfaction with the discharge process is really reliant on their understanding of expectations around discharge, including the timeline, expected milestones, and their education. Both parents and nurse satisfaction with the process of discharge are key indicators at Highlands Ranch. So we really wanted to do our best to support that. Again, as we talked about previously, discharge preparedness has been shown to be most optimal when it starts shortly after admission and is performed throughout the hospital stay rather than all at the end information overload right as you're getting ready to go home. And use with discretion. Maybe the minute of admission is not a good time for people to be receptive to learning, but as soon as possible in that admission process to start chipping away at those education topics. We've also talked about some language barriers. I feel like even just communication from different NICU staff can be confusing for parents. We might have the same message, but different terms we use or different styles of communication. So trying to give the family something concrete to refer back to so that they have a more clear expectation of what the baby needs to do to be able to go home. Prior to making this roadmap, we did not have a family-based tool in our NICU. As part of my preparation, I also did a literature review of 5 different articles from the Journal of Neonatal Nursing, Journal of Pediatrics, and Advances in Neonatal Care. These also showed that there's a direct link, again, between patient satisfaction and discharge readiness. That a standard tool with the option to individualize or customize to the baby is helpful. Again, that education should start as early as possible in the stay. A visual tool is preferred in some of the studies, and that for this tool to be really optimally successful, the rollout, utilization, and staff engagement are essential. So I went back to the Define Collaborative with my ideas and my research. Of course, they supported the idea of putting together a roadmap and were instrumental in some of the data collection pieces of things, as well as the edits of the roadmap. After doing my research, I also looked at other examples of visuals used at different hospitals and outlined the inclusions that I wanted to have. Then put it more into a actual visual. I did have to work extensively with the UC Health brand team to kind of design and modify to meet our brand requirements. Keep in mind that our NICU at Highlands Ranch is an 8-bed, pretty much a level 2 NICU. I mean, we can take down to 30 weeks, but these road maps were designed for our population, mostly feeder grower land. So then to facilitate the rollout on the unit, I did provide an in-service to the NICU staff so they could become familiar with the roadmap versions, layout, and desired utilization. They are a one-time use handout given to the families to like interact with, update as appropriate, and kept at the bedside throughout the admission. This next slide shows an example of, actually, let me go back a second because I don't think I went through this whole thing. So I did come up with two different versions, one to acknowledge like the longer NICU stay, again, for our level 2 NICU, and a shorter NICU stay. This is to provide a concrete reference for the parents to monitor progress and their anticipated next steps. The backside also has education topics correlated to each of the colors on the roadmap, which you'll see. Those topics are taken directly from CRAMES and EPIC. So those specific titles can be given to parents in their preferred method of learning. So here's that visual. You can see the top right-hand corner is the specific discharge criteria so that parents can have an idea what their final end goal is. And then starting along the left side there, NICU welcome is just kind of unit orientation, care times, how the family can start being involved. And then flowing through the frequent or the usual labs that we look at, weaning, IV and respiratory support, starting developmental therapy and oral feedings. Again, some things like learning how to bathe and family interaction in that sense. Medications that we give, common imaging that is done, and then learning to feed. So that roundabout is there on purpose to say, as we all know, like some babies just get stuck kind of going around the same Groundhog's Day over and over again until they're really ready to go home. So taking their ad-lib feeds, gaining weight, and getting things ready to go home, and the discharge tests that they need to do, car seat study, et cetera. Here's the backside. This is a bit busy. These topics are not required to have them all addressed during this day, but rather to use as like families can look and say, hey, I want to know more about prematurity. I want to know more about heel sticks. I want to know more about apnea. And the nurse can look up that exact title and print out the education topic for them, or actually send it through my virtual workplace. I would like to streamline this a little bit more to be a little user-friendly. I think people look at it and just are overwhelmed and don't know where to start. I also did bring examples of the actual roadmaps today if anybody's interested in seeing them in person. Since the initial rollout, we also added a process for milestone pictures, which is really fun. We have to obtain a photo consent from the parents before taking any pictures, and then we have a Polaroid camera. We're working on a better quality camera as well, but then we can take pictures of the milestones, whether the family's there or not. It makes the roadmap a little more exciting to see their pictures on there. So this roadmap was provided by a family, and you can see kind of how they checked off the different milestones, and then with the pictures to correlate with the first full bottle or 5-pound club and those sorts of things. There's a list of my references. That's it for me.
Thank you so much, Gina. All right, we do have a couple minutes for questions. So if I can have all 4 of the presenters come on up and we'll open it up to questions. All right, I'll get us started. You know, all 3 of these units are really different, right? In terms of the patients, the types of conditions, the length of stay. What in your units was the biggest facilitator in the success of each of the things that you presented. I'm trying to get a sense of what are some core components or core things that units have that support success of family engagement efforts.
Nursing buy-in.
Yes, that's exactly what I was going to say.
Nursing buy-in.
Say more.
I mean, all of these guys can speak to it, right? The interventions that have been most successful in our unit are those that where the genesis of the idea was either directly from families and then with a strong second by nursing, or things that nursing had already identified as pain points for our patient care.
I think in collaboration with the Define Collaborative, working with families and bringing that perspective back to help support the nurses buy-in has been very helpful. I think all the nurses in our unit know what safe sleep is, but then we fall into these habits of not practicing that at the bedside. But when we brought up, like, this is something that families have brought up that they see as they're getting ready to go home and a challenge that they're facing, that's kind of impacted their buy-in to why it's important to be doing it. So.
And I think for us, just in the length of time we spent with families, we really noticed there was a missing gap, and if there was an opportunity for us to do better. So I think it came from both physician and social work and myself. So just really seeing there was a missing link.
We have a question from a participant online. Modeling safe sleep in NICUs, what is the best strategy for modeling with babies struggling with severe reflux? Back is best is a very challenging guideline for parents who go home with reflux babies that choke on their backs. Reflux is not always resolved before discharge from the NICU. And anonymous is who said that, so.
Better answer, but some of the education that we've provided, we haven't gotten to the final stages of this yet, but what we've kind of emphasized is that actually back positioning puts them at less risk for aspiration related to their position. And so all research now is showing that GERD does not have a positional treatment plan. And so that being head of the bed up or in a swing or other items can actually put them at more risk for aspiration, which is kind of different in a shift than what we've been seeing before. That probably doesn't quite answer the question, but we haven't quite gotten to other supportive modalities of reflux as they're getting ready to go home, besides really emphasizing the education on the anatomical positioning and protecting the airway.
Questions? All right. Well, thank you so much. I'm going to pass it back to Sarah.
Okay, we're going to move back to our small groups. This time, it's going to be a little different though. Our goal is to think through one or two things that you could do tomorrow to start the process of change in your unit. As a parent, how can you get involved? As a provider, how could you find information? Who would you talk to? Share the ideas. Really, the goal is to walk out of this room knowing I have one thing or two that I can do as an action item tomorrow. Okay. Oh, and we have 20 minutes, y'all, because Rebecca keeps looking in the door because we're behind.